Has there ever been a moment when your heart seemed to kick into overdrive, racing like a thoroughbred with no finish line in sight? You might find the culprit in a condition known as Atrioventricular nodal reentry tachycardia, or AVNRT for short. This heart rhythm disorder is often the unseen hand behind that sudden rapid heartbeat. AVNRT is the most common non-sinus tachydysrhythmia in young adults, presenting as a regular, narrow, complex rhythm with a ventricular rate that quickly scales over 130 beats per minute, sometimes even surpassing the 160 beats per minute mark. So what triggers this heart-racing phenomenon? It all boils down to the heart's electrical system. AVNRT is birthed from a re-entry circuit within the AV node, the heart's natural pacemaker. This results in normal conduction down the bundles of His, a troop of heart muscle cells that specialize in electrical conduction. Retrograde conduction, also known as inverted P waves, are usually tucked away within the QRS complex, traveling upwards into the atria, the heart's upper chambers. AVNRT typically has a sudden onset and end, frequently surfacing amidst strenuous exercise or emotional stress. Common symptoms include palpitations, shortness of breath, and sometimes chest pain. However, hemodynamic instability is an unusual guest unless an underlying cardiopulmonary disease is present. If the heart doesn't slip back into its regular rhythm independently or via vagal maneuvers, the first-line therapy for AVNRT is usually a drug named adenosine. This is administered as a rapid, large-bore IV bolus followed by a flush. This method proves successful in 85 to 90% of cases and is deemed safe. In stubborn cases, other pharmaceutical options include diltiazem, esmolol, or metoprolol. In rare cases, synchronized cardioversion might be necessary for AVNRT that's resistant to drug therapy, or in a patient with hemodynamic instability. Interestingly, AVNRT usually doesn't demand specific laboratory testing. Mild troponin level elevations may occur, but are of uncertain significance aside from concerns for myocardial ischemia. Most patients can be discharged after terminating AVNRT with adenosine or vagal maneuvers and typically require no further testing beyond an ECG. For those who experience frequent recurrences, prophylaxis with a beta blocker or calcium channel blocker or ablation therapy might be considered. Starting prophylactic therapy is appropriate for those patients with an established plan for follow-up. To sum it all up, AVNRT is a heart rhythm disorder that triggers a sudden, rapid heartbeat. It's born from a re-entry circuit within the AV node and is often treated with medication or vagal maneuvers. Even though it can be a cause for concern, the majority of AVNRT cases can be effectively managed, enabling patients to return to their regular routines and regain control of their heartbeats.